Hello, I'm Mark Toyer, one of the emergency medicine residents at Duke. Today we will be talking about deep venous thrombosis. Here are our learning objectives for this lecture. Today we would like to discuss the common risk factors and common clinical presentations of deep venous thrombosis. Next, we'd like to cover how are we going to diagnose deep venous thrombosis, and then when we do diagnose it, how are we going to treat it. Next, we'll briefly discuss some complications of deep venous thrombosis and why do we care about making this diagnosis. Here's the outline for the talk today. First, we will go over some background information. Next, we will move straight into how to diagnose deep venous thrombosis. Thirdly, we will go into how to treat deep venous thrombosis. And lastly, we will review any common complications of deep venous thrombosis. Here, let's talk about some background and definitions. Venous thromboembolism is an umbrella term that includes both deep venous thrombosis and pulmonary embolism. Deep venous thrombosis is by definition a blood clot in the deep venous system. This is in contrast to clots in superficial veins. Most commonly, deep venous thrombosis occurs in the lower extremities, but it can also occur in the pelvis or alternatively the upper extremities as well. Regarding the incidence of the condition, a recent review article found that deep venous thrombosis occurs in 48 people per 100,000. DVT occurs more often in the elderly and is slightly more common in men than women. For example, DVT occurs in 49 per 100,000 of women aged 50 to 54, as opposed to 70 per 100,000 of men of the same age. In women aged 60 to 64, it occurs in 100 people per 100,000 versus 128 per 100,000 for men of the same age. By comparing these four incidences, we can see that DVT occurs more commonly as we age, especially above the age of 60, and is slightly more common in men than women of the same age. Let's talk about risk factors for deep venous thrombosis. Who should we be especially vigilant in making the diagnosis? As we all remember Virchow's triad of hypercoagulability, stasis, and vessel injury predisposing a clot, it's easy to see how the following can predispose somebody to develop deep venous thrombosis. Cancer and thrombophilias make one hypercoagulable. Recent immobilization and surgeries can damage the blood vessels or lead to stasis, and age can both predispose to immobilization and vessel injury. The clinical presentation of deep venous thrombosis is relatively straightforward. Essentially, the patient will present with unilateral leg or, less commonly, arm swelling. The swelling will not be explained by infection, trauma, or other obvious cause. For example, often an extremity infected with cellulitis will often be more swollen than the contralateral leg. Although bilateral swelling of your extremities from a proximal clot is possible, other metabolic or cardiac causes should be considered in this case, as DVT much more commonly presents with unilateral extremity swelling. Continuing on with the diagnosis of DVT, many of you are familiar with the Wells score for PE. The purpose of the Wells score is to use a given patient's risk factors and clinical presentation to risk stratify them for PE. Similarly, there is a Wells score for DVT. As you can see, it incorporates the risk factors and clinical presentation that we talked about previously. For example, a patient is given 1 point for active cancer, recent immobilization, bedridden or recent surgery, fusiform swelling of the extremity, asymmetric swelling of the calf, or pitting edema confined to one leg, or new collateral superficial veins, and having a history of deep venous thrombosis. And if there is another alternative explanation, as least as likely as DVT, the patient is subtracted 2 points. This might occur in the cellulitis case as described previously. So what is the utility of the Wells score for DVT? Essentially, patients are grouped into 3 categories based on their Wells score. Low, your Wells score is 0. Intermediate, you have 1 or 2 points. And high, you have 3 or more points. The significance of this is that a D-dimer blood test can be used to rule out DVT in low or intermediate risk patients. In clinical practice, the Wells score and D-dimer are rarely used. However, the Wells score codifies the risk factors and clinical presentations formally to help us risk stratify patients in our mind. One scenario where a D-dimer may be used is in a community emergency department that does not have ultrasound availability at night. Today, the mainstay of diagnosis of deep VT is ultrasound. Essentially, the ultrasound looks for DVT by assessing the compressibility of the deep venous system, the logic being that if a vein is not compressible, there is likely a clot present. Ultrasound has very good sensitivity and specificity for DVT. A recent review article found that the sensitivity was greater than 94% and was even more sensitive for proximal DVT, which is the more common. Sometimes in clinical practice, you will have a patient that you judge to be at very high risk and have a classical story and presentation for DVT, but the ultrasound will come back negative for DVT. What do you do then? Often, these types of patients will be instructed to undergo a repeat ultrasound in 1 to 2 weeks, the logic being that the repeat ultrasound may catch a DVT present that was missed on the initial study. The mainstay of therapy for DVT is anticoagulation and prevention of both propagation of the clot and future clots. In the acute settings, most patients will be started on anticoagulation with Lovenox or heparin. Lovenox has the advantage of being able to be continued as an outpatient and given subcutaneously, but care is advised with patients with impaired renal function. This is in contrast to the other option, heparin, which requires a constant IV infusion and serial blood monitoring in a hospital setting. In rare cases, an interventional radiology procedure will be performed to remove the clot in extreme circumstances. This is in contrast to the anticoagulation therapies which just prevent future clots. Let's move towards discussing the complications. Why do we care about making the diagnosis of DVT, and why are we obligated to treat it? Pulmonary embolism is a feared common complication. Clots embolize from the DVT, return to the heart, and are pumped into the pulmonary circulation, obstructing blood flow and causing pulmonary infarction. As you know, pulmonary embolism can be a life-threatening diagnosis, and this is something that we'd like to prevent if we know somebody has a DVT. Another potential complication is potential arterial compromise of the affected extremity. A phenomenon called phlegmatia cerelia dolens, which translates to painful blue edema, may be used to describe the syndrome of obstructed arterial blood flow to the affected extremity. In these cases, an interventional radiology procedure may be considered. Post-thrombotic syndrome is also another complication and relatively common. Essentially, this is a syndrome of chronic leg pain and swelling due to DVT. It is hypothesized that the damage to the vein and valves leading to chronic inflammation and venous incompetence is responsible. In summary, we have covered the risk factors, the clinical presentation, the diagnosis and the utility of ultrasound in making the diagnosis of DVT. We've covered the treatment and learned that the mainstay of therapy is anticoagulation and prevention of clots and interventional radiology procedures in extreme circumstances. And we learned that the most commonly feared complication of DVT is pulmonary embolism, as well as impaired arterial circulation and chronic pain. Here are some of the key references used to produce this presentation. Thank you for your time and attention.